Good morning in the West Coast. Good afternoon in the East Coast, and the rest of the world. Good morning, good day, good noon, good afternoon, good evening, and good night. It is an honor and privilege to be with you again. I'm Dr. Camran, the founder of the Worldwide EndoMarch on Endometriosis Day. And we are very honored and pleased to have another extraordinary panel today to discuss the role of endometriosis in patients with infertility, undergoing different procedures of assisted reproductive technology to get pregnant. And they have received many, many questions. The panelists, beside my co-founders, Dr. Farr, Ceana, and Azadeh Nezhat, are the esteemed colleagues from New York, Dr. Sheeva Talebin, a reproductive endocrinologist, and from San Francisco, a very esteemed colleague of ours, Dr. Aimee Eyvazzadeh, and from the Los Angeles, another all very esteemed REI, Dr. Kelly Baek. All of them, they know each other, and it is a fantastic team we have put together. The mission of the Worldwide EndoMarch since 7 years ago, when we started, has been to increase awareness about endometriosis and empower women and young girls with endometriosis to take control of their life to a large degree. And since in its inception, it is in more than 63 countries, and many other organizations have followed suit, and we are very happy to see this progress is going on. And the virtual meetings have been very successful. And this meeting, we have received many questions. Each participant would answer one question, and at the end of all the questions that we have received, we have tried to answer the questions that addresses almost everybody, because the questions, there were too many. So many of you might not see exactly yourself, but similar to you, we have tried to choose the questions that are not repetitive. And the next session, again, we have taken a poll from you as you have requested. The next session next month will be about endometriosis, pain, and the bowel endometriosis. So at this stage, stopping the introduction, I would start with the first question. And the first question is from Dr. Ceana Nezhat, and the question is, I am 27 years old and I have deep fibrotic endometriosis. I have had surgery recently, and I would like to know how long do I have to get pregnant? Dr. Ceana Nezhat.
Hello, and thank you for the opportunity to be with you today. Fertility enhancing surgery with endometriosis, it requires additional skill, and it's not just limited to excision. Considering the fact that this individual is 27 years old, and if the condition I am sorry, I had to unmute. It's a pleasure to be with you today, and this is a very good question, specifically that the individual is 27 years old. Considering that if the sperm factor, the condition of the tubes are good, then it all has to do with the skill and experience of the surgeon who performs treatment of endometriosis. I'd like to reemphasize excision of endometriosis for infertility patient is not necessarily always the best choice. The surgeon who performs endometriosis surgery requires more knowledge and skill than just excision. considering that if the surgeon has performed adequate treatment and there is no harm to the ovaries and the tubes, this person could try minimum 3 months. In most cases, I allow my patients to go 1 year without interfering. And the chances are very good. In 1 year is more than 70 to 80%. Thank you. You are muted too.
I think, Zoe, please try not to mute me. Just let me be unmuted, please. I appreciate it. So the next question is for Dr. Sheeva Talebin. She's in an RUI in New York. Dr. Talebin, the question is, patient says, I am 37 years of age. I have had multiple failed IVF, and I have had PGD, and I have no symptoms at all. What is my next chance? How do I know if I have endometriosis or not, and what should I do?
Great. So this is a great question, and I think a very common patient scenario that I see in my practice in New York City. So, historically, when IVF was not as successful, meaning we weren't as good in the IVF lab at making chromosomally intact, high quality embryos, when we did the implants and the patient had a negative pregnancy test, we just typically blamed it on the embryo. But nowadays, we're really very, very good at making high quality chromosomally intact embryos. And when patients start to fail repetitively, at this point, we have to start thinking outside of the box, and that it might not just be embryo related, and it could be something related to, is there an implant failure issue? Is there an immune issue? Is there blood flow issues? But one of the things we have to start to consider in this scenario is, could there be, significant endometriosis? Maybe the woman doesn't have severe pain. Maybe we don't necessarily see evidence of the endometriosis on the ultrasound, but could there still be a fair amount of endometriosis and inflammation? And could those negative inflammatory factors in the pelvis somehow potentially be preventing implantation to occur? Again, 15, 20 years ago, when we first started doing IVF, we thought, okay, endometriosis, just take the eggs out of that environment, make the embryo in the lab, put it in the uterus, and the patient gets pregnant. But again, as we've gotten so much better at making embryos and there are patients not getting pregnant, we do have to consider endometriosis in this exact scenario. So what do we do? And this is what's hard is, obviously you want a high level ultrasound, good physical exam, any evidence of endo on the exam. There is, a uterine biopsy that many of us in the fertility world use, called the receptiva biopsy. That's an endometrial biopsy that looks for a protein called BCL6, that if this is highly positive, may suggest inflammation and endometriosis, and kind of go down that pathway. But for sure, in this exact patient scenario, it's something she should bring it to the attention of her RE and say, maybe I do have inflammation, and what can we do to learn about it, and then what could we do to potentially treat it before another implant.
Thank you very much, Dr. Talebin. The next question is for Dr. Baek, who is in Los Angeles. And the question is, I am 33 years of age. I have had many failed IVFs. All of my tests are normal. Her husband's tests are all normal. And she said that it has been recommended to her to have adoption. She wants to know if there is anything else she can do.
So first of all, I think if you're having that, the questions that I would want to know is, when you had your failed IVF cycles, were these genetically tested embryos, and what cycle day blastocysts were they? Were they structurally normal as well? Because you have to look at whether an embryo is not just structurally normal, but also genetically normal. That's number one. Number two, especially before you move on to something like adoption when you're young, you may consider getting a second opinion with another fertility specialist just to get a second pair of eyes. Even if everything was perfect, it wouldn't hurt you to consider getting a second opinion to look again and recheck, was everything truly normal? So you would want to look at the semen analysis. Was the morphology normal? Because the morphology is more consistent with the DNA potentially of the sperm. If the morphology is low, did you check a DNA fragmentation? For the woman, even if you're doing IVF and you know you're going to have an embryo transfer into the uterus, was the hysterosalpingogram performed? What you would want to know is the uterus perfectly normal? Is there anything that would prevent implantation? Even if the tubes are patent, you'd want to know, everything in our body should be asymmetrical. And so if your uterus is deviated to one side, or your tubes are technically open but dilated to a certain degree, one of the things I always think about is endometriosis. Because really what would cause the uterus to be deviated to a side is potentially if you have an inflammatory process in the pelvis. What it can do is it can cause scarring of one of the uterosacral ligaments that can cause that kind of deviation. So in addition to that, I'd want to make sure you have a normal ultrasound, your hormone profile. As we all know well, the thyroid when you're not trying to get pregnant should be above 4 to 5. But when you are trying to get pregnant or are pregnant, we would want that TSH to be less than 2.5. And finally, in addition to considering checking the uterine lining on a microscopic level, I know with Dr. Talebin, the Ceana is great, but I would also consider something called the endometrial function test, which I utilize quite often whenever there's recurrent pregnancy losses or recurrent failed cycles. It's a test that was created out of Yale with Dr. Kleiman, and you're looking at to see whether or not the lining develops properly, if you have the necessary proteins to support a live birth, and if there are inflammatory cells or an underlying infection. Whenever I've seen inflammatory cells, specifically macrophages or leukocytes in the lining, or evidence in someone who had completely normal tubes on a hysterosalpingogram, but there's fluid in the on the biopsy sample that's suggestive of hydrosalpingo still, I have sent them to Dr. Nezhat specifically to have them assessed for endometriosis, even in these completely asymptomatic women. And then finally, I would really have them consider getting a laparoscopy and hysteroscopy to make sure there isn't something missed on the uterus. Yes, your uterine cavity may be totally normal in shape, but however, what if the perfusion's not normal? Maybe you have a pale area or a flat scarring called Asherman syndrome. And on laparoscopy, Dr. Nezhat has oftentimes looked for not only endometriosis in these asymptomatic women, but you can also see whether or not the fallopian tubes are perfectly healthy and normal and not just patent. So that's what I would consider before moving on to something like adoption.
Thank you very much, Dr. Baek. The next question is for Dr. Aimee Eyvazzadeh, that she practices in the San Francisco Bay Area, and the patient says she is 38 years of age. Her husband is 45 years of age. They have tried multiple IVFs and it has failed. They have had a Receptiva test which showed positive for inflammation. And following that, she received a 3-month period of Lupron. And after that, she tried IVF again and it failed. What are her options? What should she do, Dr. Eyvazzadeh? You are, please unmute, Kelly. Please unmute.
Hi, everyone. Can you hear me? Thank you again for having me. I'm Dr. Aimee, and thank you to all the Dr. Nezhats and all the panelists for all the work that you do. So for this patient who's 38, who's been given a diagnosis of no explanation, I always say, let's see what the possible explanations could be. I have a very straightforward approach I use for each of my cases. I call it the egg whisperer diet. D is for diagnosis, and really talking through what all the possible diagnoses could be. And for someone who's over the age 35, you always have to wonder if egg quality is an issue. So at 38, we know each egg has about maybe a 25% chance of being genetically normal. So considering PGTA would be something important to do if this patient hasn't done it already. And egg quality has to do with age, and age stands for age, genetics, and environment. So whatever you can do that's in your control to be as healthy as possible also help with your embryo quality. So ask your doctor about your embryo quality. The I of the diet is IVF and considering PGTA would be potentially helpful in this case. And the E is endometrial testing. So you've done the Receptiva test, but maybe consider, just like Kelly mentioned, the EFT test. I also like the ERA test. I know that these are a whole bunch of acronyms, but your doctor, if they have experience with the Receptiva test, they probably have experience with the ERA test as well. And maybe consider doing more IVF, freeze more embryos, and then as far as the transfer goes, pick a time in your life which is the least stressful as possible. And sometimes when you've been through as much as you've been through, it might be helpful to think a little bit outside the box. I'm not a huge fan of immune testing, but I think women who have endometriosis might have some immune system dysfunction that might be addressed with other types of treatment modalities that I won't mention here. It's important to talk to your doctor about those. Thanks, guys.
Thank you very much, Dr. Aimee. The next question is from our niece, Dr. Nezhat, who is a reproductive surgeon. The question is, patient says she is 40 years of age and all of her adult life she has suffered from endometriosis. Now she has a 13-year-old daughter who has started having her period, and that is very painful, and she wants to know if endometriosis is hereditary. What is her next option? What should she do? Please unmute your microphone. Zoe, please keep everybody's microphone unmuted. Okay, sorry.
Thank you for that question. The genetics of endometriosis and inheritance of endometriosis is a complex issue, but most investigators and the authorities feel like it has components of polygenetics and environmental factors that affect endometriosis, which means that it's not one gene that is inherited, and the fact that you have endometriosis and in your case severe endometriosis, your daughter is more likely to have endometriosis. You can think of it as something like heart disease. If you have family history of heart disease, you're more likely to have heart disease, but that doesn't necessarily mean that you will have heart disease if you watch your diet or exercise. So this is similar to endometriosis. Your daughter is likely to have it, more likely to have endometriosis, but I think you should consult your, be aware of the signs and symptoms and kind of make sure she knows about it and seek help early on to hopefully have a more positive effect on her growing up without pain. And if it's the infertility is the issue, you can, once she's aware, she could seek help early on.
Thank you very much, Dr. Nezhat. The next question is for Dr. Farr Nezhat in New York. He's a GYN oncologist. The question is, this patient has bilateral ovarian endometrioma. She has cysts on both ovaries in each side, and one of her IVF physicians didn't want to aspirate the endometriomas. Another IVF physician said, well, I like to aspirate these endometriomas, and so the other one said, no, I am concerned about ovarian cancer. The question is, what are the risks of ovarian cancer in these patients with endometriomas, and what should she do? What do you recommend?
Hello, everybody. It's a pleasure to be with you guys. And there are a couple of questions. What is the incidence of the cancer in patients with endometriosis? Overall, in the lifetime of the patients with endometriosis is a 2 to 3% that could develop cancer. So the risk is not very high, fortunately. However, ovarian endometrioma, the incidence of the cancer on that endometrioma ranges from 0 up to 15%. Depends how does the endometrioma looks like. If
there is no solid component on the endometrioma and the radiologist could describe homogeneous type of cyst, the chance is almost zero. But if there is any solid component by the ultrasound or especially by MRI, then you have to be careful. That could be cancer. Or if the endometrioma gets large in a very short time, that could be a sign of the cancer. Overall, it is not a very good idea to aspirate any cyst that is suspicious for malignancy. So I agree with that physician that says do not aspirate. The other problem with the aspiration of the endometrioma or chocolate cyst is that this is old blood, and it is not very easy to aspirate the old blood. And there is a risk of the contamination of the endometrioma with bacteria from the vagina and get infected. So overall, we do not recommend to aspirate the endometrioma via transvaginal approach because there is a risk of infection. Thank you.
Thank you very much, Dr. Farr. The next question is for Dr. Kelly Baek. And the question is, the patient says that she has a large endometrioma, 7 centimeter, and she would like to know if she should have her endometriosis and endometrioma treated before egg recovery or after egg recovery. What are your recommendations? What should she do?
When you have 7 centimeter bilateral endometriomas, I would recommend that you remove the endometriomas by excision therapy by an endometriosis specialist first. And the primary reason for that is because we know that when the endometriomas of that size in the ovaries are present, you may not stimulate as well even if you're doing an IVF cycle. Second, during the IVF egg retrieval, based on that large size, even if the follicles in the perimeter, it would be really challenging to avoid the endometriosis of endometrioma. And certainly we know that when parts of the endometrioma is aspirated in the follicular fluid, I consider it to be toxic to eggs. Immediately when I'm doing an aspiration of an egg and we see any chocolate fluid, our surgical tech immediately separates that follicular fluid from all the other tubes. The embryologist also separates it because we do worry that there could be a negative component in terms of how that egg will fertilize and develop. So I do think that, especially when you have 7 centimeters, to remove it first. Prior to surgery, I do recommend getting an AMH test done because you want to know what your ovarian reserve is prior to going into surgery. And you can check that post-surgery as well, and check a semen analysis, because during that time of healing, if there's a male factor, you can certainly help address and try to improve that sperm, because half the DNA is sperm and half the DNA is egg. So when the surgery is done, at the time of surgery, the surgeon can also reevaluate the fallopian tubes, not only to check is it patent, but is it perfectly healthy? Because as we know, fertilization occurs in the fallopian tube if you're going to try naturally. And also you want to know, where is the ovary located? Is it scarred down? Will it be possible to conceive without IVF? Would the sperm and egg actually be able to meet in the fallopian tube? So I think those are all important questions. And that would help determine what your treatment options are post-operatively. So based on, I always try to ask patients, my goal here is to find out what are your fertility goals. If you want more than 1 child and you have a low ovarian reserve, should we consider freezing embryos first for the future? And then the treatment options would determine, after we harvest embryos, if they want more than 1 child, is to consider, okay, is your fallopian tube completely healthy and patent? Is the sperm perfectly normal? And then if it is, I usually would monitor cycles to try to help my patients conceive for about 3 months post-operatively with either timed intercourse or an IUI. But if either the fallopian tubes are damaged, they have a very low ovarian reserve, or there's male factor, then I do recommend IVF with PGS testing. And so to me, those are the main considerations: are what are your fertility goals and what's affected. But certainly I would always recommend removing those large endometriomas first, because I do think the environmental milieu of the inflammation can be harmful, not only towards an IVF cycle when you're trying to stimulate, but also when you're undergoing a frozen embryo transfer, because we know inflammation can lower implantation.
Thank you, Dr. Baek. The next question is for Dr. Aimee, and the question is, patient says that she's 28 years of age. She has had 4 failed IVF, and she is fine. All of her tests are normal. Her husband's tests are normal, but they are suspicious of her having endometriosis. But patient says her IVF physician believes endometriosis doesn't interfere with her getting pregnant, and she wants to know why. And what do you think?
I mean, as a 28-year-old, obviously I'm not 28, but it's so frustrating to not be heard, because young people often are told, don't worry, you're young, it'll happen. So the fact that this 28-year-old has already gone through 4 IVF attempts that haven't been successful, I imagine she is at her wit's end. So what I would say is listen to your gut or listen to your uterus. So if you feel like you are having a problem with endometriosis, do some diagnostic tests to see if that's going on. We've mentioned a test called the Receptiva test, so that's one thing that you can do. But I would also just kind of take a step back and, just like Dr. Baek was mentioning, get your AMH tested again, do a semen analysis with a DNA fragmentation test, look at the embryo quality, consider PGT, go through those steps that I mentioned, those 4 steps, the diagnosis, and see what the possible diagnosis are for you. Why are you doing IVF in the first place? And then try to fix everything that you can possibly fix that's in your control. But I think sometimes when you've gone through IVF that doesn't work, it could be the embryo quality. Try and get as much transparency and information from your doctor as possible. Look at the embryos. Sometimes things are sugarcoated and your doctor says things like, oh, your embryos are just fine. It should work eventually, but the reality is that your embryos are really low quality and you weren't given that information. So ask about that quality of your embryos, what the percentage rate of implantation should be for each embryo. Think about doing PGTA. And in cases like this, in young people, sometimes patients are told you don't need PGTA because you're so young, but this might be a situation where it would be extremely beneficial. And if I have a patient who's this young and who chooses not to do it, I will now always do a chromosome analysis on both partners to make sure that neither one of them have a structural rearrangement in their DNA. And it could be that the embryos are abnormal and the efficiency of IVF would be a lot lower, and that might be something that someone who's that young would want to know before they keep going through more cycles. But listen to your uterus.
Thank you very much, Dr. Aimee. The next question is for Dr. Talebin, and the question is that is it possible to get pregnant if endometriosis has spread to your ovaries?
Okay, great question. So yes, absolutely. So endometriosis, when present, most often is on the ovary. It may not be a clear-cut endometrioma seen on an ultrasound, but if that woman has surgery, there's probably some small lesions. So it's, you know, if there is endometriosis present, there's a high likelihood that it also is somehow on the ovaries or impacting the ovaries. And so you know, we spoke a little bit, Dr. Baek, you know, very nicely explained a case of, you know, a patient with large endometriomas on their ovaries and what the approach would be. But again, if there is endometriosis on the ovaries, I think it just depends on the extent and whether or not surgery might be recommended prior to doing other forms of treatment. But of course, you know, the whole thing that we've all talked about, you know, this patient should be evaluated, have an AMH hormone. You know, for those of you not familiar with that, it's a marker for your egg quantity. So that would be, you know, very helpful to have. And again, if the endometriosis looks very significant and is occupying a bulk of the ovaries, you may want to, you know, definitely meet with an endometriosis specialist, a surgeon, and discuss removing that prior to potentially trying, you know, actively to conceive or to proceed with IVF. But absolutely, you know, the assumption is that if you have endometriosis, it probably is somehow somewhere on your ovaries and impacting those ovaries. And absolutely, you can still get pregnant, sometimes naturally, you know, unassisted, sometimes assisted.
Thank you very much, Dr. Talebin. The next question is for Dr. Aimee, and the question is, I am 43 years of age, and I have had many IVFs, and I have had only chemical pregnancy. My embryos are all good. This is what she said. Could I have endometriosis, and is it possible, and can surgery help me?
Great question, and I would say that the majority of my practice is women who are over the age of 40, and a large majority are even over the age of 42. So this is something that I personally see a lot, and it's a very frustrating problem because you feel really healthy and you feel really good and you're making these beautiful blastocysts, but at the end of the day, they're just not working. So I think talking about embryo viability is really important. What the likelihood that each embryo will be normal at the age of 43 is helpful going into it. I review something called the IVF attrition pyramid with each of my patients, and I give them a very clear idea as to what the expectations from treatment should be at their age. So if an embryo has normal chromosomes in this 43-year-old and they're still resulting in chemical pregnancies, certainly we want to do implantation testing. The tests we talked about already, like the Receptiva test and the ERA test, can certainly be helpful. And also look above the uterine lining, see if potentially these are recurrent ectopics that are happening. Is there fluid in the tubes? I mean, these are the standard tests that OBGYNs will do. Fertility doctors as well, if a patient has recurrent biochemicals, even outside of IVF. And sometimes doing recurrent pregnancy loss testing could be helpful in this situation, especially if the embryos are normal. For example, looking at an anatomic defect in the uterus, which most of us will do ahead of a transfer, looking for an autoimmune issue, a thrombophilia. Those are just some of the standard things that we would do as part of our workup in a patient who's 43 who has good embryos and is having recurrent biochemicals. So make sure the tubes are open, see if the chromosomes of the embryo are normal, and then look really carefully at the lining. And if you have just one chance to have a healthy pregnancy and you're going through something like this at the age of 43 and these are your own eggs, at this point, sometimes you might want to consider a gestational carrier. Those are the things that docs like us would bring up with our patients.
Thank you very much, Dr. Aimee. The next question is for Dr. Talebin, and the patient is 25 years of age. At the age of 21, she undergoes surgery for severe endometriosis, extensive, and she has tried to get pregnancy successful. And she, due to financial limitations and lack of insurance, and also because of her own health, she doesn't want to undergo any kind of hormonal treatment or IVF or ovarian stimulation. She wants to know if there is any other options for her. Should she try other ways to, is there anything else could be done to help her get pregnant?
So let me just make sure that I'm unmuted. Okay, so good. Oops, sorry, I cut up my video, sorry. So this is a tough case. So, a 21-year-old who underwent extensive surgery for endometriosis, who's now 25, who is having difficulty conceiving and is very concerned about hormonal therapy. Again, most certainly, while she may be reluctant to undergo treatment, she should absolutely meet, with a reproductive endocrinologist, undergo all the various testing, including tubal assessment, ovarian reserve testing, semen analysis, do as much testing as possible. And then depending on the results, talk about options. But, as Western trained physicians, most of our treatment to help patients get pregnant does involve some sort of ovarian stimulation therapy, inseminations in an office, or IVF. There are alternative options if she's very reluctant to go the Western route. There are, Eastern adjuncts and anti-inflammatory diets and anti-inflammatory acupuncture and herbal treatment. But at the end of the day, given her history of extensive endometriosis, she very likely, will need something like in vitro, if her tubes are no longer functioning. And, given her age, even if she has a very low AMH or low ovarian reserve, her egg quality still should be very strong. And I would say it's kind of now's the time to do the treatment. And I think that there are also a lot of myths and misconceptions about IVF treatment and what it could do on the body and what subsequent impact it may have on the ovaries. So I think this is the exact patient, while she has, kind of a lot of preconceived ideas about what she may or may not want. I think she needs really, really good counseling with a physician that she feels comfortable speaking to and safe, and then making an informed decision about what kind of treatment is best.
Thank you very much, Dr. Sheeva Talebin. The next question is for Dr. Kelly Baek in LA. And the question is, a patient says she is very symptomatic. She has a lot of pain and problems with endometriosis already. And how should she go about how to add an extra burden of receiving so many fertility medications? How do you deal with that?
Right. So with these patients, I usually like to get an assessment of how conservative I can be with their treatment. So it's important to know how old they are, because if they're younger, we can be a little bit more conservative with proceeding with treatment or not. I'd like to check the age also. It's not predictive of live birth, but it does tell us what our ovarian reserve is. And as Dr. Talebin and everyone else has mentioned already, is to make sure that the semen analysis, HSG, are complete normal, as well as the ultrasound, so that we know, could conception happen naturally without IVF, or will we need IVF? Following that, I have a holistic approach where I work with a real network of people to try to address this. I work with mind-body specialists as well as acupuncturists who specialize in fertility. And I think in the right hands, they can oftentimes try to help. There's pelvic floor therapists who specialize in endometriosis. And believe it or not, women who have endometriosis, and even if it's undiagnosed or misdiagnosed, because 1 in 10 women do have endometriosis, what I found is that by the pelvic floor therapy in the right hands can help increase blood flow to the ovaries, so you actually have more ovarian activity. It can help alleviate some of the discomfort. And finally, if they're still symptomatic, then I would definitely have them consider having surgery. If they have a good ovarian reserve, then post-surgery, I would want to make sure that we try to alleviate their pain and their symptoms first. And following that, I would monitor them in a natural cycle to ensure that they're ovulating properly. Simply because you're ovulating, it doesn't mean you're ovulating in a good size or that you're not ovulating a post-mature egg. You want to make sure that, conception has been optimized, because the longer you wait, when there's a higher estrogen, the endometriosis is a lifelong entity where it will come back. So the goal would be to try to help them conceive sooner than later, to use minimal stimulation if possible. And so that would be my initial approach. But I found that when you have a holistic team, holistic with the WH, when you have a holistic team approach and you have a real support network for patients with this who are symptomatic, they tend to do pretty well with surgery. And oftentimes, once they're pregnant, it's amazing how a lot of their symptoms are relieved, because they're, I don't know if this is the stretching of the uterus, Dr. Nezhat, you probably know this better, or because they're not ovulating anymore, but people tend to feel much relief once they're pregnant.
Thank you very much, Dr. Aimee, Dr. Kelly Baek. The next question is for Dr. Aimee, and the question is, patient says she is 34 years of age. She has had many failed IVFs. Her husband, all of her husband's tests are good, but she has bad eggs, and also the embryos that they are produced are not good. So, and she is asymptomatic. She wants to know if she has, is it possible that she might have endometriosis? And if so, could surgery possibly help her?
That's a great question. Yeah, I mean, as far as low egg viability and embryo viability, it's also the same causes as I stated before: age, genetics, and environment. So the environment could be endometriosis affecting egg quality. And a woman who doesn't necessarily have symptoms and doesn't have obvious signs like endometriomas on the ovaries, it's less likely that endometriosis is causing her poor egg quality, but it's definitely worth looking into. One of the things that I sometimes consider doing in a case like this is potentially, if she needs to go through more IVF, is doing a Receptiva test during her IVF cycle. So either doing it at the time of the egg retrieval or a week later. This information can potentially provide her some diagnostic clues as to what's going on. But some other things, just unrelated to the question, a woman who's 34 could consider doing, who's had multiple failed cycles, is potentially consider other protocols medications to help with egg quality like HGH. Ask your doctor about that. And then talk to your doctor about what their experience is in cases like yours, as far as what your chances are of getting pregnant. What is the, experience of the lab? Do they have the newest technology? Do they have the right certifications? Because maybe it might be time to find another center that might be more suitable for you and your case.
Thank you very much, Dr. Aimee. Next question is for Dr. Talebin. The patient has a question. Unfortunately, she hasn't said her age, but Dr. Talebin, perhaps she could address it if the patient is around 30 years of age or if patient is around 40 years of age. So let's say if patient is around 30 years of age and she has had recently a miscarriage, and since then, about 11 months ago, she has been trying to get pregnant, and she hasn't been successful. And she also has a very painful period. She doesn't want to have IUI or IVF. What are her options? If the patient is 30 or if the patient is 40, because she has not, how old she is, we extreme that these two ages, please.
Right. So exactly. So, again, very, very common scenario. A 30-year-old starts trying, gets pregnant maybe pretty quickly, but then has a miscarriage, and now is trying, for months without success. So, again, doesn't want to do treatment, but you should still speak to a reproductive endocrinologist at this point. You've been trying for over a year, you're under 35, you haven't had a successful pregnancy. So first is, okay, what are the various causes of miscarriage? Why could that miscarriage have happened? Yes, it could sometimes just be bad luck, and young women also have miscarriages as well, for sure. But again, this is a patient who needs a full workup, ovarian reserve testing, a transvaginal ultrasound, an HSG, semen analysis. If she hasn't had preconception genetic screening, her and her partner should undergo that. But again, it depends on what any of the testing shows. Many times, 20% of the time, the testing is all quote unquote normal. So it's now technically unexplained infertility, and she's 30 years old. So what I always explain is, okay, your options are to, maybe take an oral medication to augment your ovulation, something like Clomid or Letrozole, track the ovulation, do an IUI. So in a case of unexplained infertility, what's the purpose of something like Clomid and IUI? I say, well, it's trying to target something that's going on that we're not able to pinpoint. So it's just trying to, make your timing more accurate, bring egg and sperm closer together. If that doesn't work after about 3 trials, we do usually progress to IVF. However, if the patient says, okay, I've listened to everything, I have unexplained infertility, there's no major red flags, I don't want to do this treatment, what should I do? I say, okay, again, you can try the Eastern route, acupuncture, herbal treatment, track your cycles. But I always explain the more and more months that go on that you're not successfully conceiving, the bigger and the more real the issue is. And oftentimes we say IVF is both therapeutic and diagnostic. It's therapeutic in the sense that it's dramatically increasing your odds of a pregnancy, and it's diagnostic in the sense that it gives us information as to what's going on with your embryos. Now jump ahead to that same patient who's 40, and it's a little bit the discussion becomes a little more sort of serious in the sense of, okay, all the same testing for that 40-year-old, it's the same battery of tests. It's just that we know that egg quality at 40 is very different than it is at 30. And therefore she really may not have the luxury of time. That 30-year-old can try for a whole other year unassisted. And if her AMH was good and her day 3 FSH was normal, she may not be dramatically lowering her odds if she doesn't rush right over to treatment. But a 40-year-old, unfortunately, the average 40-year-old doesn't have that luxury of time. And so she just needs to really be adequately counseled regarding what all her testing shows, what the implications are, what her chances are of trying unassisted, what her chances are of trying with, therapy like IUI or IVF. you know, what I always say to these patients is my job is to give you as much information as possible so that you can make the best decision now and not look back at this time with regret. Because we've all had it where they come to our offices 3-4 years later at 43, 44, 45 and say, I wish at 40 I had done, you know, IVF or egg freezing. And so, you know, again, our job as a fertility doctor is to give these patients all the tools they need to make the right decisions in real time, and that we don't want them looking back with regret.
Thank you very much, Dr. Talebin. The next question is for Dr. Baek, and patient says she has been diagnosed with endometriosis and currently trying to conceive. How long should I try before looking to specialists for assistance? What can specialists do for me? Additionally, is there anything I can do, like lifestyle changes, diet, etc., to help to increase my chances?
Sure. So I think this is really important, and Dr. Talebin and Dr. Aimee both highlighted it, is to know, first of all, how old is this patient who was diagnosed with endometriosis. So if you already know you have endometriosis, we know that potentially they may have a lower ovarian reserve than other women their age. Even if they've never had chlamydia or gonorrhea or any pelvic surgery, they may have tubal disease. So I would want to have them consider getting a fertility assessment early on, even before they start trying, to ensure that they're not wasting their time. Since we know that endometriosis is a progressive disease that's lifelong until you go into menopause, you may want to know ahead of time, what is your ovarian reserve? Is the semen analysis normal? Are your fallopian tubes open so that pregnancy can actually occur naturally? So when you're trying, if it turns out that your tubes are blocked or the semen analysis is really compromised, you know that you haven't wasted your time trying to conceive, because I can't tell you how many times I've seen women to find out after they've been trying only to discover that their tubes were blocked or the sperm is really compromised. And so that's something you may consider. And again, even if the sperm's compromised, because the life cycle of sperm is 2 to 3 months, it's something that we can help address and try to improve once we uncover what the issue is. The other thing is about the lifestyle. There are a lot of things that can affect, which we can try to do to optimize success. So if the tubes are pain and the hormone panel is normal and the semen analysis is normal, I really go through all the lifestyle issues. We know sleep is critical. Sleep is important because our pituitary pulsatility occurs at night. So women who don't sleep well, change time zones often, are under a lot of stress, may not ovulate properly. Whenever I have a concern that someone may not be ovulating properly, I will monitor them in a natural cycle to ensure that. I also want to make sure, what is their diet? Are they doing something like a low calorie restrictive diet, keto or Atkins, where I've seen that you may not ovulate properly or you can diminish your ovarian activity? What is their exercise like? Are they just doing normal cardio? Are they swimming? Or are they doing high intensity workouts where you can really shut your ovarian activity down? We know what, I can never tell someone don't be stressed out, because I think that can cause more stress, but I'd also want to look at what is their overall well-being and their stress level. Finally, I want to know socially, are they smoking a lot of cigarettes, pot, or vaping? Unlike men who are always making new sperm, we're born with our eggs, and we know that smoking, pot, vaping can actually diminish our ovarian activity and our reserve and quality of our eggs as well. Do they have a history of an eating disorder? And do they have any chronic medical illnesses? If you do have a chronic medical illness, it's really important to consider trying to get that under your control. If you have a medical illness that has an autoimmune component, for example, like a thyroid disease with autoimmune antibodies, we know that that can age your ovaries more quickly. And that may change how long you'll try naturally if everything else is normal. And finally, age is the #1 predictor of live birth. So if you're younger, you may consider trying on your own naturally for like 6 months. And if you're older, you may not try on your own at all, or consider trying on your own for about 3 months.
Thank you very much, Dr. Baek. The next question is for Dr. Nezhat, and the question says, patient says, my mom had endometriosis. She also, patient has had endometriosis herself, stage 4, which affected her ability to get pregnant. Her doctors took good care of her, and through IVF, she got pregnant with frozen embryo transfer. Her baby now is 7 months old, Her question is, what are her chances that her daughter might also have endometriosis? And she has heard that some physicians tell younger women to go ahead and get pregnant early because her best chance is when they are younger to get pregnant. And but she said this is not a good solution. What are her options? When should she consider freezing the eggs of her daughter?
Okay, I think in this case, the most important thing is educating your daughter. It is important to be aware of the early signs of endometriosis since she's only 7 months old. Being aware of the early signs of endometriosis is very important. And I think to be cognizant of the fact that the endometriosis could affect her fertility in the future, those are the most important thing to me, and that I would say she should be aware of. Also, as we said before, there is if she has a family history of endometriosis, if she has endometriosis and her mom has endometriosis, the likelihood of her daughter having endometriosis is high, and hopefully if early on she's educated and she has those symptoms, she should seek professional help early on. That could help. Hopefully by the time she is in the reproductive age, there are more treatments and more, hopefully there's even possibility of a cure for endometriosis, but freezing her eggs at the appropriate time, that most certainly is an option. I think it's hard to say they should have children at early age because she has hopefully about 18 to 20 years of ahead of her, and things could change. So I think educating her is the most important thing, and making her aware of the signs and signs of endometriosis, to me, would be the appropriate thing to do. And most certainly if she is at the age to preserve her eggs.
Thank you very much, Dr. Azadeh. So the next question is for Dr. Aimee, and it's interesting. This patient has been a patient of mine, and her question is, I am 35 years old medical student who has had surgery with Dr. Camran Nezhat 5 years ago for advanced endometriosis. My husband and I live in different states and recently got pregnant, but then had a miscarriage. There was no evidence of intrauterine pregnancy or ectopic pregnancy. On ultrasound and her beta HCG goes from 900 to 3 within 3 weeks. She's planning to check her AMH and do an HSG as well. She wants to know what next steps are recommended for her.
Excellent. So this is a 35-year-old medical student who has a husband that lives out of state with the diagnosis of severe endometriosis. And at that age, I would strongly suggest freezing eggs, embryos, or both. So embryo freezing will give her at least help her secure future options for baby number 2. It doesn't mean that she needs to use the embryos for baby number 1, but that's something that I would highly recommend. Any woman who is over the age of 32 who already doesn't have 2 or at least 1 child and wants a chance of 2, I highly recommend, if you're partnered, freezing embryos. If you're 37, for example, and you already have 1 baby, consider freezing embryos, So we don't want to take this woman's age for granted, and the diagnosis of endometriosis makes her egg quality a little bit lower and potentially could affect the implantation rate as well. And then as she's preparing for transfer, when she's going to get pregnant, if she does choose to use those embryos, consider treatments for endometriosis to prevent the progression of endometriosis, especially because we know that it can affect the walls of the uterus. She may have adenomyosis at some point in the future if she doesn't already, and that could be what's causing the implantation issues that she heartbreakingly just went through. So my heart goes out to her, and I hope that she is successful. And I would just tell her to do the work of freezing embryos so that hopefully she has the chance of having a healthy baby now, and then in 2 or 3 years, she can have a healthy baby then.
Thank you very much, Dr. Aimee. And we have time for perhaps one more question to get everybody on time, and some announcements that I would make at the end of the this question from Dr. Talebin. And once again, I want to thank you. And this last question, patient says she has been diagnosed with endometriosis at the age of 27. Her AMH has been 0.85 and AFC 13. She had regular periods until she was diagnosed with a 9-centimeter endometrioma, and that was a surprise to her. Her mother history has had early menopause around the age of 40. She is not actively trying to get pregnant, but she has frozen some eggs, and she has gotten only 2 mature eggs that are well below her average age. She has had 14 days of menopause and gonorrhea at a very high dosage, has been triggered with Lupra. She wants to know which protocols and triggers do you like to use in endo patients with low AMH for her age group. How many eggs should I try to bank given the potential for low quality as a result of her surgery perhaps? Is it recommended 14 eggs given her age is still she should have 14 eggs freezing? Additionally, she wants to know how many eggs freezing are too many. My endo doctor doesn't want me off the birth control pill, but I am worried it is too suppressive if I want to have another round soon. Dr. Talebin?
Okay, so not a straightforward case. So she's in her late 20s, known endometriosis with a very low AMH. So if I understand correctly, though, her AMH is 0.85 and her follicle count was pretty decent. I think you said 13. So, you know, it's interesting because she did a cycle and she only got 2 eggs. Based on her AFC and AMH, I would have predicted that she would make more. And it sounds like she was on a max dose protocol. And while it's almost counterintuitive, sometimes these patients may do better with slightly lower dosages. Sometimes you can use something like letrozole or Femara in conjunction with something like Gonal-F and Menopur as well for the stimulation. So, you know, there's a handful of different protocols out there. I always say that IVF is both, it's as much an art as it is a science. And so when you try one protocol and you don't have the desired outcome, you may really want to try to switch things up. And sometimes, again, it sounds counterintuitive, but sometimes we go less aggressive with the gonadotropins and add in some oral agents. And sometimes those patients end up doing better. You know, in an ideal world, in your late 20s, given the history, you know, yes, the more eggs she has frozen, the more insurance policy moving forward. In terms of how many is too many, you know, there's no data per se that multiple rounds of the treatment can increase, you know, your cancer risk. Obviously, you want to be vigilant, do breast exams, make sure there, you know, if there's a strong family of breast cancer, that's a different story. But in the average, you know, woman who doesn't have that risk factor, I don't, you know, we don't have a limit per se, but again, also, we don't need to be max dose, full dose each month that she tries this. So, you know, there are ways to sort of tweak the protocol, maybe a more what we call milder / gentle protocol that she may actually even do better with. And, you know, I think in an ideal world, if she is able to have about, you know, 15 eggs aside, that's great. But again, you know, these women need to just be counseled that there's only so much, you know, there's so much we can do now to protect ourselves for the future. And they also need to have a frank conversation with this patient about, you know, down the road when you know, maybe, you know, come to use those eggs, or if you're trying naturally or whatever it might be, but down the road, if none of these eggs are viable, what are your other options? And I think it's important to, you know, discuss, even though she may be so young, they need to understand there's no guarantees that these eggs may work down the road. There is something called donor egg, there's adoption, a lot of other options to become a parent. But again, you know, it's all about the counseling And you know, each month you can kind of tweak the protocol and just try to see if there are better ways, you know, to optimize the outcome.
Thank you very much, Dr. Talebin. This has been the most fantastic and fascinating virtual lectures and presentations by the very esteemed colleagues, Dr. Baek, Dr. Eyvazzadeh, Dr. Talebin, the co-founders of the Worldwide EndoMarch, Dr. Farr Nezhat, Dr. Ceana Nezhat, Dr. Azadeh Nezhat. Also, I would like to thank significantly we have had 3 of our fellows, Dr. Asiai, Dr. Ramon, and Dr. Ramon, that they have been fielding the questions that they have been coming live, answering people online. Also, I would like to thank the co-founder of the Worldwide EndoMarch for all of her efforts, Dr. Barbara Page, also Tiffany, Zoe, and Elisa for all of their efforts. Thank you very much. Please look at the barcode behind me. You can use that barcode for some more questions. Also, the endometriosis can be diagnosed. There is a Nezhat endometriosis advisor that was developed for Worldwide EndoMarch, and it is completely free. It is a guide to help those of you who can try to see if you have endometriosis or not. It is highly accurate. And the next meeting would be about bowel endometriosis and pain, what to do, when, what not to do, the role of surgery, and what kind of surgery. I'd like to thank all the panel again, and also especially all of you around the world who have been the loyal followers of the Worldwide EndoMarch, and for your support to help yourself. Thank you very much, and wishing you a fantastic weekend. Bye-bye.
Bye-bye, everybody.